Study cards, Module 4, Psychiatry. Coach Study cards, Module 4, Psychiatry.
Piaget has 4 stages. The mnemonic, Society for the Prevention of Cruelty to Fruit. Sensory motor, pre-operational, concrete operational, formal operations.
This chart shows Erickson's stages. We're going to break this down into little bite-sized pieces. Next, we're going to work on the PEG system. That's how we bring this all together. For the PEG system, you simply memorize these 8 words in order. 1 bun, 2 shoe, 3 tree, 4 dinosaur, 5 diver, 6 sticks, 7 heaven, 8 plate. And then you put picture mnemonics onto those words. 1 bun, rust, trust, trust versus mistrust. 2 shoe, autonomy versus shame, shame driving an auto. 3 tree, initiative versus guilt, quilt wrapped around a tree. 4 dinosaur, industry versus inferiority, an inferior dino standing on dust. 5 dive, identity versus ID confusion, diver dents a car. 6 sticks, intimacy versus isolation, intimate sticks and the loner. 7 heaven, generativity versus stagnation, stag running heaven's generator. 8 plate, integrity versus despair, grits and a pear. These are the conflicts. We're going to list the conflict, the life event, and the outcome on each slide. How you remember these is the mnemonic, how poco fool cow. Hope, will, purpose, competence, fidelity, love, care, wisdom. Infancy, trust versus mistrust, feeding, hope. Early childhood, autonomy versus shame and doubt, toilet training, will. Preschool, initiative versus guilt, exploration, purpose. School age, industry versus inferiority, school, confidence. Adolescent, identity versus role confusion, social relationships, fidelity. Young adulthood, intimacy versus isolation, relationships, love. Middle adulthood, generativity versus stagnation, work and parenthood, care, maturity, ego integrity versus despair, reflection on life, wisdom. We're going to break down the ages into a memorable package. 1 is birth to 1 year. 2 is 1 to 3 years. 3, 3 to 6. 4, 6 to 12. 5, 12 to 20. 6, 20 to 35. 7, 35 to 65. 8, 65 to death. To break these down, remember 1 plus 2 times 2 times 2 plus 8 plus 15 plus 30. These are the conflicts. 1 is trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt, industry versus inferiority, identity versus role confusion, intimacy versus isolation, generativity versus stagnation, ego integrity versus despair. Training number 2, Piaget's stages of development. Here is a table with the details on these things. You can fill in the details once you have the So Peter Can Fly memorized. Training number 2, Piaget's stages of development. Piaget 2, 7, 11, 12 to adult.
Piaget has 4 stages. The mnemonic, Society for the Prevention of Cruelty to Fruit. Sensory motor, pre-operational, concrete operational, formal operations. First stage, sensory motor, 0 to 2 years, object permanence. Motor, sensory motor. 2, permanence. Stage 2, pre-operational, 2 to 7 years, magical thinking, conservation of energy is difficult, egocentric, assimilation. Pre-operational, magical thinking, 7 magic bunnies. Conservation, assimilation. Stage 3, concrete operational, 7 to 11 years, logical thinking, accommodation. 7-11, concrete, logical, accommodation. Stage 4, formal operations, 11 plus years, abstract thinking. Formal, 11-7, abstract.
Training number 3. Freud's psychosexual stages of development.
The mnemonic for Freud's psychosexual stages. Orangutans always play with little gorillas. Orangutans, baby gorilla, oral, anal, phallic, latency, genital. Stage 2, oral, 0 to 18 months. "18 apes, totally oral fixation, feeding, and the mouth." Next stage, anal, 18 to 36 months. 36 more toilets, totally fixated on all things anal and bowel. Commodes. Third stage, phallic, 3 to 6 years. Genitals and masturbation. Gentle bears, masturbakers. Next stage, latency, 6 years to puberty. 6 to pubes. No. Latent period, no real activity. Final stage, genital, puberty, and from there on. Pubes all the way. Maturation of sexual orientation.
A table with the basics. Oral, 0 to 18 months. Mouth sucking, biting, chewing. Anal, 18 to 36 months. Anus, bowel, and bladder control. Phallic, 3 to 6 years. Genitals and masturbation. Latency, 6 years to puberty. Repression of sexual feelings. Genital, puberty on. Maturity of sexual orientation. Training number 4. Freud's defense mechanisms. Projection, displacement, sublimation, denial, intellectualization, rationalization, repression.
The 7 basic Freudian mechanisms: projection, displacement, sublimation, denial, intellectualization, rationalization, repression. The 7 basic Freudian mechanisms: projection, displacement, sublimation, denial, intellectualization, rationalization, repression. Psychoanalytic perspective, defense mechanisms. Projection. Disguise one's own threatening impulses by attributing them to others. Rationalization. Offers self-justifying explanations in place of the real, more threatening, unconscious reasons for one's actions. Reaction formation. Switch unacceptable impulses to their opposites. Regression. Deal with anxiety with an infantile method of coping. Sublimation. Converts unpleasant energies into positive or useful ones. Displacement. Shifts sexual or aggressive impulses toward a more acceptable or less threatening object or person. Repression. Banishes anxiety, arousing thoughts, feelings, and memories from consciousness. Defense mechanisms. Ego's unconscious distortion of reality It protects from psychological pain, trauma, anxiety, fear, and unacceptable urges or wishes.
You can use this table to attach the defense mechanisms to the idea of a personality cluster. This is that same table broken down into a more bite-sized version. Paranoid delusions and projection, substance abuse and denial, acting out, borderline personality disorder and splitting, passive aggressive, enuresis and regression, somatoform disorders and somatization, phobias as a result of displacement, blunted affect of schizophrenics and isolation of affect, obsessive compulsive anxiety disorder as a result of intellectualization, obsessive compulsive behaviors in undoing, dissociative disorder in depersonalization. Peplau's stages. Orientation. You focus on the patient needing help and the nurse establishing a connection. Identification. The patient begins to identify with the nurse and feels a sense of belonging and capability in dealing with their problems. Exploitation. The patient actively utilizes the services and resources offered by the nurse to achieve their goals. Resolution. The nurse and patient mutually agree that services are no longer needed, or the patient is left with a plan for continued health. Training number 5. Motivation theory, based on the trans-theoretical model of change, Prochaska and De Clemente. Pre-contemplation, contemplation, preparation, action, maintenance. Thinking about motivation theory. It's non-confrontational. Avoid confrontational answers. The goal is eliciting changes when the patient is ready to change. Use the patient-centered empathy statements and empowerment. Basic skills of motivation interviewing. Mnemonic OARS. OARS. Open-ended questions. Affirmation, a compliment to build on what the patient is doing correctly. Reflection, rephrasing statements and exploring feelings to amplify or reinforce the changes. Summarizing, ensure understanding, clarification, discrepancies, and listening. In motivational interviewing, you place the patient in the driver's seat to navigate conversation actions and set SMART goals. 5 A's of motivational interviewing and behavior change model. Ask, advise, assess, assist, arrange. Frames. Feedback, responsibility, advice, menu, empathetic, self-efficacy. For motivational theory, 5 A's, frames. Motivation therapy is based on the motivation theory, which comes from the trans-theoretical model of change. Pre-contemplation, contemplation, preparation, action, maintenance. Motivation therapy is based on the motivation theory, which comes from the trans-theoretical model of change. Pre-contemplation, contemplation, preparation, action, maintenance. Motivation therapy is based on the motivation theory, which comes from the trans-theoretical model of change. Pre-contemplation, contemplation, preparation, action, maintenance. Motivation therapy is based on the motivation theory, which comes from the trans-theoretical model of change. Pre-contemplation, contemplation, preparation, action, maintenance. Training 6. Trans-theoretical model of changes. Pre-contemplation phase. The patient is unaware of a problem. No initiation of changes. Action. Provide feedback to raise awareness. Do not give advice. Don't tell them what to do. 2. Contemplation phase. Fully aware of the behavior, but not committed to change. Action. See the benefit of change and the consequence of not changing the behavior. 3. Preparation phase. The key is making plans to change. Action. Find realistic resources for change. 4. Action phase. The patient is taking actions to change, for example, attending AA meetings. Action. Provide encouragement and specific advice to continue the changes. Motivation therapy is based on the motivation theory, which comes from the trans-theoretical model of change. Pre-contemplation, contemplation, preparation, action, maintenance. Training number 7. Lewis's change theory. He theorized a 3-stage model of change known as the unfreezing, change, refreeze model, which requires prior learning to be rejected and replaced. Kurt Lewis. Driving forces. Driving forces are those that push in a direction that causes change to occur. Restraining forces, those forces that counter the driving forces. Equilibrium, state of being where driving forces equal restraining forces and no change occurs. Stages in this theory. Unfreezing, help patients get off old patterns that were somehow counterproductive by increasing the driving forces, decreasing restraining forces, and a combination of those two methods. Change stage, moving to a new level or movement, involves a process of change in thoughts, feelings, behaviors, or all three that is in some way more liberating or productive. Refreezing, establishing the change as the new habit so that it now becomes the standard operating procedure. Without this final stage, it can be easy for the patient to go back to old habits. Training 8. Cognitive therapy. Aaron Beck changes the irrational beliefs, negative thoughts, and cognitive distortions. Thoughts and behaviors influence our feelings, a treatment process that allows patients to correct their false self-beliefs or distorted thoughts and perceptions that were responsible for negative mood, behaviors, and anxiety. Training 9. Behavioral therapy. The goal is to change the maladaptive behaviors with positive actions. Action-based therapy that is based on the notion that all behaviors are learned and can be changed. Techniques, exposures and relaxation, skills training, problem solving, role playing, and modeling. Behavior therapy is composed of exposure, role playing, and modeling. Training number 10. Cognitive Behavioral Therapy, CBT, aims to change the patterns of our conscious and unconscious beliefs and behaviors to overcome problems and issues. Examples: journaling, cognitive restructuring. CBT therapy has two aspects. It replaces negative and distorted thoughts with positive thoughts. It also combines the benefits of problem solving, skills training, modeling, exposure, and role playing to give more effective tools for depression and anxiety symptoms. An example is using daily logs of symptoms, diary, journaling, to reflect on and improve experiences. A chart detailing some aspects of cognitive behavioral therapy, CBT. Training 11. Dialectical Behavioral Therapy, DBT, Marcia Linehan. DBT, decreased behaviors, borderline personality disorder, teach. Deal with stress, self-manage, regulate emotions, focus on behaviors that don't serve the patient. DC steps, improve then DC. These are the goals of DBT. Decrease, crisis-generating behaviors, suicidal behaviors, therapy interfering behaviors, emotional reactivity, passivity, self-invalidation. Improvement in decision-making, communication. Training 12. Existential theory, issues of existence. Goal: to understand the patient's subjective experience, focus on the present, and personal responsibility. Useful for those with terminal illness, suicidality, or crisis in life transitions. Reflection of life and subjective experience. Self-confrontation is encouraged by reflecting on their own life. Life is meaningless. What is the reason for my existence? Training 13. Humanist Therapy. Carl Rogers, Person-Centered Therapy. Rogerian, a type of Gestalt therapy. Everyone has the potential to live their best lives. Only humans deal with higher functions such as self-actualization, self-directed growth, and finding meaning. Rogers, Person-Centered Therapy. Person-centered therapy is a non-directive insight therapy based on the work of Carl Rogers, in which the client does all the talking and the therapist listens. There's 4 elements. Reflection, a therapy technique in which the therapist restates what the client says rather than interpreting those statements. Unconditional positive regard, referring to the warmth, respect, and accepting atmosphere created by the therapist for the client in person-centered therapy. Empathy, the ability of the therapist to understand the feelings of the client. Authenticity, the genuine, open, and honest response of the therapist to the client. Training 14. Interpersonal Therapy. This is not couples therapy. It's by Clearman and Weissman. Gestalt therapy. It is founded by Fritz Perls, Laura Perls, and Paul Goodman. It focuses on present moment awareness. Techniques like empty chair dialogues and role-playing help clients understand their current feelings and needs. Emphasizes personal responsibility. Clients are encouraged to take ownership of their choices and actions. Techniques. Present moment awareness exercises, role-playing, and unfinished business dialogues help clients gain insight into their experiences and behaviors. Similarities. Gestalt therapy versus humanist therapy, person-centered therapy. Both of these emphasize the concept of Gestalt, or understanding things as wholes. Both advocate for focusing on the present moment and immediate experience. Both recognize the influence of past experiences on the present. Both encourage individual responsibility and self-awareness. Check. Training 14. Interpersonal Therapy. This is not couples therapy. It's by Clearman and Weissman. Address and manage interpersonal problems. Mitigate conflicts to alleviate distress for the client. Concentrate on resolving interpersonal conflicts and relationship issues. IPT emphasizes interpersonal issues as a source of distress for clients. Effective for depression, eating disorders, substance use disorders, and marital discord. A time-limited, present-focused, and diagnosis-targeted intervention spanning 12 to 16 weeks. Concentration on here and now by resolving issues related to the identified problem area, aiming to improve interpersonal relationships and adjust relationship expectations. It follows a holistic approach that has an underlying assumption that past and present relationships of a person play a role in the origin of arising concerns. The goal is to improve relationships and change expectations surrounding the relationship. Can especially help clients with relationship, marriage, problems, and concerns. Training 15. Maslow's hierarchy. Maslow posited that human needs are arranged in a hierarchy. Human beings are motivated by a hierarchy of needs. Needs are organized in a hierarchy of prepotency in which more basic needs must be more or less met, rather than all or none, prior to higher needs. The order of needs is not rigid, but may be flexible based on external circumstances or individual differences. Most behavior is multi-motivated, simultaneously determined by more than one basic need. The mnemonic for Maslow's hierarchy. Please select levels serving self. Physiological needs, safety and security, love and belonging, self-esteem, self-actualization. BES, Maslow. Biological, physiological, safety, belonging, esteem, self-actualization. This is the pyramid that is Maslow's hierarchy of needs. It moves from basic needs to psychological needs to self-fulfillment needs. It follows a holistic approach that has an underlying assumption that past and present relationships of a person play a role in the origin of arising concerns. The goal is to improve relationships and change expectations surrounding the relationship. Can especially help clients with relationship, marriage, problems, and concerns. Training 16. Eye movement desensitization and reprocessing. PTSD, achieve adaptive. Mnemonic for EMDR. Helpful penguins are definitely incredibly busy creating recipes. History taking, preparation, assessment, desensitization, installation, body scan, closure, re-evaluation. The mnemonic for EMDR, all the parts of it, is how pretty are diamonds in bright color red. History, preparation, assessment, desensitization, installation, body scan, closure, re-evaluation. Breaking them down further. History taking is gathering information about the client's past trauma or traumas. Preparation, building trust with the client and teaching relaxation techniques for self-regulation. Assessment is identifying target memories and negative beliefs associated with the trauma. Desensitization, using eye movements to process distressing memories. Installation, strengthening positive beliefs about the traumatic events. Body scan, releasing any lingering physical tension or discomfort associated with the memories. Closure, ensuring the client is stable and feeling safe at the end of the session. Re-evaluation, assessing progress, identifying new target memories, and making treatment plan adjustments. For EMDR, you must recognize the goal is to achieve adaptive resolution. Shapiro.
Training 17. Family System Therapy, also known as Systemic Family Therapy. It's all about self-differentiation, triangles, and genomes.
Family System Therapy. Triangles. Triangulations, self-differentiation, genograms. This therapy treats the whole family, especially focusing on the anxiety that affects everyone in the family. It's about helping each family member see their own role and how they contribute to the family's overall functioning. The key concepts are self-differentiation. That's recognizing that each person in the family is unique with their own thoughts and emotions that make them different from each other. Tools and techniques, triangles. A way of understanding how two stressed family members might involve a third person to reduce their own tension, which can lead to complications. Tools like triangulations, self-differentiation, and genograms help families understand their dynamics and relationships, which is the heart of family system therapy. In simpler terms, family system therapy helps families understand how they are connected, how each person's unique personality affects the family, and how they can manage stress together without causing more problems. It uses different methods to explore family relationships and find healthier ways for everyone to interact.
Training 18. Structural Family Therapy. It's all about genomes, joining, role-playing, setting boundaries, and reframing.
Structural family therapy, framing, genogram, boundaries, reframing. This therapy looks at the family as a system with different parts, like subsystems and levels of authority. We check how family members connect and if they have clear roles and rules. How does it work? We watch how family members interact directly to help them change in a good way. The way the family is organized is important for making these positive changes. Hierarchy. What's the main goal? We want to change the family structure to help them handle problems better. Tools we use. Genogram, a family map that shows who's in charge and how everyone fits together. Joining, the therapist becomes a temporary family member to better understand and help. Role playing, family members act out their problems to spot and fix what's not working. Setting boundaries, we help the family set clear rules to improve their function. Reframing, the therapist gives new ways to think about problems, making everyone feel better and work together more effectively.
19. Strategic Family Therapy. It's all about directives.
Strategic family therapy, directives. Straightforward directives, metaphorical directives, paradoxical directives. Reframing. Strategic family therapy explained. This therapy focuses on specific problems and looks at the family as a whole system. The therapist gives the family tasks called directives to help them achieve their goal. In short, strategic family therapy is about giving families different types of tasks that are cleverly designed to help them work through their problems. Together, it's like a therapist giving a family a set of tools and strategies that might seem unusual at first, but are actually aimed at helping them in the long run. Different kinds of directives. Straightforward directives, these are clear tasks given to the family when they're expected to follow the therapist's guidance. Metaphorical directives, these are indirect suggestions used when talking about a problem directly might make family members too anxious. Paradoxical directives. These are tricky instructions where the family is asked to do something that seems the opposite of what they should do. It is used when a family member is resistant or unlikely to do what's asked directly. Reframing. This is when the therapist helps the family see their problems in a new light, which can make the issue seem more manageable and understandable. Training 20. Miracle. Solution-focused therapy. This therapy is all about setting goals and working towards them. It emphasizes using what's already working well, strengths and resources, to achieve desired changes for the future. The key is to find solutions rather than dwelling on the origins or reasons behind a problem. There's a mnemonic for this therapy: miracles accept some coping compliments by scaling walls. Miracle question. We ask clients to imagine a world where their problem has vanished overnight to explore what changes that would bring. Exception finding questions. Exception finding questions. We look for times when the problem wasn't there, which can reveal hidden solutions. Coping questions. We discover how clients have dealt with challenges, highlighting their inner resources. Compliments. We recognize and celebrate the client's achievements and strengths, offering encouragement. Scaling questions. Clients rate how bad the problem is on a scale, which helps track progress over time. In essence, solution-focused therapy is like being a detective of the good in someone's life. It's about finding those bright spots where things were going well and using them as a map to navigate out of the problem areas. It's less about digging up the past and more about building the future. 21. Multi-system therapy. Teenagers. MST is made for teenagers, especially those between 12 and 17 years old. It's a powerful therapy that happens at home and in the community for young people who have committed serious crimes and might also be dealing with substance use issues. It teaches families how to create a supportive environment that helps these teenagers stay on the right path. What MST does helps parents learn new ways to handle problems and guide their children. The main goal is to reduce criminal activities and the need for teens to live away from home, like in juvenile detention. How MST works. It combines different therapy methods like cognitive behavioral therapy, strategic family therapy, and structural family therapy. The do loop process is used to figure out and change antisocial behavior. In short, multi-system therapy is like a toolbox for families of troubled teens. It gives parents ways to help their kids avoid trouble and teaches them to solve problems effectively. The focus is on changing behaviors that lead to crime, so these teens can have a better future without needing to be removed from their homes. Training 22. Irvin Yalom, Group Therapy. Universality. Universally, members recognize that other members share similar feelings, thoughts, and problems. Altruism. Members gain a boost to self-concept through extending help to other group members. Installation of hope. Members recognize that other members' success can be helpful and they develop optimism for their own improvement. Imparting information. Education or advice provided by the therapist or group members. Corrective recapitulation of primary family experience. Opportunity to reenact critical family dynamics with group members in a corrective manner. Development of socializing techniques. The group provides members with an environment that fosters adaptive and effective communication. Imitative behavior. Members expand their personal knowledge and skills through the observation of group members' self-exploration, working through, and personal development. Cohesiveness. Feelings of trust, belonging, and togetherness experienced by the group members. Existential factors. Members accept responsibility for life decisions. Catharsis. Members' release of strong feelings about past or present experiences. Interpersonal learning. Input. Members gain personal insight about their interpersonal impact through feedback provided from other members. Interpersonal learning. Output. Members provide an environment that allows members to interact in a more adaptive manner. Self-understanding. Members gain insight into psychological motivation underlying behavior and emotional reactions. This is the mnemonic for group dynamics. A high soccer. Altruism. Hope. Imparting information. Imitative behaviors. Interpersonal learning. Socializing techniques. Others have similar problems. Cohesiveness of group. Catharsis. Existential factors. Refocusing change. Training 23. Tuckman's stages of group development. Pre-group stage. Facilitator's role. Crafts a group character outlining the group's mission and activities. Sets membership criteria and group size. Plans the frequency and timing of meetings. Establishes rules for joining and participating. Preparation. Develops informed consent forms for ethical practice. Creates engagement materials for use in meetings. Tuckman's stages. Forming, storming, norming, performing, adjourning. Tuckman stages for group development. Forming, storming, norming, performing, adjourning. Training 24. Adverse childhood experience. Adverse childhood experience. Negative childhood, age 0 to 17, experiences in childhood associated with heart diseases, fractures, diabetes, obesity, unintended pregnancy, sexually transmitted diseases, depression, anxiety, cancer, COPD, bronchitis, sleep disorder, dissociative disorders, eating disorders, and alcoholism. Amygdala equals history of trauma. Exposure and behavioral therapy will help the amygdala to help with negative past experiences. Training 25. Recovery model of mental health care, a holistic approach. Don't focus on diagnosis. Core premises. Possibility of recovery. It is possible to recover from a mental health condition. Patient-directed recovery. The most effective recovery path is one that the patient directs, requiring personalized and patient-led interventions for lasting change. The focus of the model. It aims not only for symptom reduction, but also for patients to gain control over their condition. It involves patients actively in their care, allowing them to learn and grow from their experiences and mistakes. Role of providers. Providers support patients in understanding themselves better, including their experiences, emotions, interests, strengths, abilities, aspirations, and capacity for resilience. Approach to care emphasizes building resilience and managing life's challenges rather than achieving full symptom resolution. Looks beyond the diagnosis and treatment with medications, focusing on the patient's abilities, interests, and dreams. Promotes self-direction and autonomy, leading to individualized, patient-centered care. Recognizes the non-linear nature of recovery, including setbacks from which patients can learn from their experience. Focus on the patient's ability, interest, and dreams.
4 pillars of the recovery model, HHPC. Health, encouraging self-management to improve overall well-being. Home, ensuring stability and safety in living conditions. Purpose, finding meaning and direction through work, education, or other activities. Community, building relationships and social networks for support and belonging. That's the 4 pillars, HHPC.
The traditional model is medical, assess and diagnose and treat. Promote clinical recovery. Practitioner has control. But in the recovery model, what is needed for well-being, individual focused, promote personal recovery, and you share control. Training 26. Assertive Community Therapy, ACT. Mental health provided to the community with an integrated approach in a less restrictive setting, not in the hospital. Emphasis on community-based treatment with emphasis on maintaining functionality instead of committing the patient to more restrictive inpatient mental health facilities. No history of medication non-adherence. Goal: integration into the community without relying on hospital care. Good for patients with schizophrenia, bipolar, etc. Treatment is patient-focused and focuses on patient needs and strengths, desires, and dreams for the future. The ACT team. Training 26. Assertive Community Therapy, ACT.